Welcome, everyone. Thank you for joining us today. We are very excited and looking forward to this conversation. Before we get started, first of all, my name is Corey Diamond. I'm the Senior Director of Development and Alumni Relations here at Fletcher. Before we get started, just one small kind of housekeeping note. Once we get to the Q&A portion of the discussion, please enter your question using the Q&A function on the bottom of your screen, and we will present your questions to the panelists. So thank you once again for joining us, and I am going to turn it over to Dean Kite.
Well, good morning, good afternoon, good evening, everybody, and welcome to the second session of our 19th annual Talloires Symposium, and the second year that we've had to do this virtually. As you know, this year we're discussing preparing for the next big crises. And of course, a year ago at Talloires, we were joined by Dr. David Nabarro, the Special Envoy of the World Health Organization for the pandemic. And he walked us through what then was the early stages of our understanding of the tenaciousness and the global impact of the pandemic. So a year on, we know a lot more about pandemics. We have a whole new lexicon around immunization and vaccines, from diplomacy to hesitancy, etc. But we can explore the origins of these pandemics and talk about how we can be prepared for the next big crises. Yesterday, I hope some of you were able to join us for a really fascinating conversation between Professors Chris Miller and Professors Josephine Wolf on cybersecurity in Russia. And that was recorded, and we'll be posting very soon the sort of recording of that for anybody who missed it. So we've set the table perfectly for today's discussion on diplomacy at the intersection of human, animal, and environmental health. We're going to take a critical look at the areas where human, animal, and environmental health meet and how we might prevent or mitigate future pandemics. We're being joined by Dean Emerita of the Cummings School of Veterinary Medicine and Senior Fellow at the Fletcher School, Deborah Kacheeva, and Triple Jumbo, Dr. Nahid Badilia, who is Associate Professor at the Lear Institute at Fletcher and Founding Director, and big round of applause, Founding Director of the Center for Emerging Infectious Diseases at Boston University. We're incredibly proud of you, Nahid. So Deborah Kacheeva served for 12 years as Dean and Henry Lois Foster Professor at the Cummings School. After stepping down as Dean, she served as Provost ad interim. In parenthesis, she's responsible for hiring me to Fletcher, and I'm delighted she did. And recently completed the Global Business Administration, the GBA degree at Fletcher. So really impressed by her multitasking. Debbie has been a leader in veterinary medicine education. She is past president of the American College of Veterinary Clinical Pharmacology and former president and chair of the board of the Association of American Veterinary Medical Colleges. She counts advancing institutional diversity, equity, inclusion as a priority in her work, and her areas of expertise include international communications and public diplomacy. She's a dedicated teacher with special interest in interprofessional One Health education and global One Health diplomacy. So Dr. Kacheeva is joined today by Dr. Nahid Badilia. Nahid is board certified infectious diseases physician and internationally recognized leader in highly communicable and emerging infectious diseases. She's also an extremely effective communicator, as I'm sure many of you have heard her on television and radio, especially here in the United States over the last few months. She is the founding director of the new Center for Emerging Infectious Diseases at Boston University. She serves on state, national, and interagency groups focused on biodefense priority setting, development of clinical care guidelines, and medical countermeasures research. She served as a clinician in several Ebola treatment units working with the World Health Organization, and is currently medical lead of a Department of Defense funded research focusing on viral hemorrhagic fevers in Uganda. Her research focuses on global health security, identification of safe and effective clinical interventions and infection control measures related to viral hemorrhagic fevers, as well as emerging infectious diseases. She received her undergraduate from Tufts, a MOld from Fletcher, and her MD from Tufts University School of Medicine. Well, we couldn't have two better people to walk us through this intersection of human, animal, and planetary health. And what a time to be on this journey. So the floor is yours, Deborah. Thank you.
Great. Thank you, Dean Kite. And I am very pleased to say that I was on the Medford campus when the totally correct decision was made to hire Dean Kite. And so I've apologized to her a couple of times, though, for the fact that she kind of signed on at the beginning of COVID. So it wasn't the perfect timing, but we're really, really pleased that she's there at Fletcher. So I'm going to share my screen and we'll get started here. All right, here we go. Okay. All right, I'm going to assume that everybody can see that okay? So I'm really pleased to join you today because I think, as Dean Kite said, my history at Tufts is really not as much at Fletcher, certainly as it is at Cummings School of Veterinary Medicine. And so what I've become really devoted to is the uniqueness of Tufts in terms of its different disciplines, its different schools, and consequently its particularly important role in terms of being a convener and bringing individuals and groups from different parts of the academy together to solve problems. Hence our title, Diplomacy at the Intersections of Human, Animal, and Environmental Health. And of course, you'll recognize that triad there as One Health. One Health is a term that perhaps has gotten overused a bit. And so, but the concept of it is absolutely basic to what we'll talk about today. The pictures there are intended to show, some of the interfaces that we think about when we think about health and especially infectious disease. So wildlife by the bat, livestock, the young boys with their goats, and then obviously a gathered group of people who are in close proximity to one another. So I'm going to start with just a few very basic definitions, which you as Fletcher alum are very familiar with. And so first of all, just the term, a very old term of diplomacy, which at its core is the art and practice of conducting negotiations. And so typically we think of those as negotiations among officials related often to foreign policy objectives. And so the objective is typically, not to go to war, but rather to work things out through talking and cooperating. So different flavors of diplomacy, hard power, economic sanctions, and military operations, and then soft power, which of course Fletcher excels at in terms of negotiating conflict resolution around cooperation and co-option. And then finally, smart power, where we combine the best of those. And now, as we'll see, we apply those in increasingly important ways to areas that have previously maybe not been on the top of mind when we think about diplomacy, but now increasingly for really the past 15 plus years are. So moving from diplomacy then to the concept of global health diplomacy. So now we're merging that concept of global health and diplomacy. Even the concept of global health, I think, is important to just pause briefly on. Previously, decades ago, before we had such rapid transportation, such a globalized economy, the idea of global health was much less important to people than what was happening in their community or in their immediate region. Now it's clearly a globalized health environment and one in which we have to think about how diplomacy plays a role. So it's multi-level, it's multi-actor, international, regional, local, community, really important community elements that are shaping the global policy environment for health. And we've all had a very dramatic example of that now with the pandemic. So if you think about diplomacy's sort of progression over the decades, going from focus on economy and trade to the environment, which of course remains a strong focus, and now really moving into this notion of a important health venue. So here's the classic One Health symbol, which of course is a great diagram to remind you of how much we people share with animals and the environment in terms of a place to live and work and hopefully be healthy. So we've kind of coined a new term. I haven't really seen it much out in the literature just yet, but our hope is to maybe do that through a unique constellation of Tufts institutions, which include, of course, the Fletcher School for the law and diplomacy piece, but also include at Tufts, which you're likely very aware of, veterinary medicine, human medicine, nutrition. We have a wonderful engineering department. We bring so many different talents to the One Health table. And so we are following that definition of One Health as a collaborative, multi-sectoral, transdisciplinary approach, very importantly, working at all these multiple levels, from local all the way to global. The key is that it is not siloed. Actually, in truth, it is siloed, right? We live in a siloed world, but a grand aspiration for One Health is to break down those silos and to do a better job of optimizing health for all of these component parts, because when we do that, everyone benefits. So for today, I really wanted to take that basic thought about diplomacy and about health and about One Health and apply it to the current situation, which is we're in the midst of a pandemic. Hopefully we're moving towards the end of a pandemic, thinking about zoonotic infectious disease. So it is a startling example of how we live One Health, and that is we share diseases. And so, so what I'm showing a diagram of, and I appreciate that the text is a little bit small and may not be so easy to read. It's a spillover ecosystem, with spillover being that concept that pathogens can move from animals to people. And that when that happens, that is a spillover event. How the pathogens adapt and are able to move and live in a new species, why that happens environmentally, and how we can intervene in that are all pressing problems. And those are pressing problems that start with the community and individuals, and they move all the way up through governments in terms of policies that can be made to either mitigate those risks or in sometimes to make them worse. So if you just look at that diagram from the point of view of the concentric rings, then you see sort of the individuals there in the center, some at higher risk than others. Healthcare workers, we know from recent pandemic, even preceding COVID, the Ebola outbreak, what high risk our healthcare workers are at. Workers in various industries, farmers, extractive mining industries, those individuals are at high risk because they often are disrupting, either through deforestation or other mechanisms, that natural environment, natural barriers that keep our pathogens to ourselves. Those folks, even though this diagram looks very articulated, there's lines between all these. And so the notion that we do live in silos too often is a feature of the spillover ecosystem that both organizes our thinking, but is in fact the basic challenge. So those individuals live within industries. We've already mentioned a few of those. They live within habitats, especially wildlife habitats, that are critical to our understanding of how pathogens move. But getting into the sort of the diplomacy layers, as you move out to the green concentric circle, now you're looking at who are the players. Well, you have governments and ministries. You have NGOs, both local and international. You have across these various entities, the important activities of making policy. As you move out to that last circle, the factors that are impacting that ecosystem, you see healthcare systems infrastructure, policies and governance, or lack of those, environmental factors. And that's really where health diplomacy or global One Health diplomacy lives, is at those interfaces that take our cues first and foremost from the stakeholders in the middle of that diagram, but then do the best we can of bringing together not just diplomacy expertise, but expertise across the health sciences, and applying that to getting where we need to go in terms of policy. So I want to move really from just, again, first that notion that Tufts is very well positioned to think about these things, to those basic definitions, 3, the example of where we are now with pandemics, and finish with just a brief mention of some of the tools that we work with. And so the most important really is the international health regulations, the IHRs. The 2005 iteration is what is most current. That they form a monitoring and evaluation framework through the WHO that has become an essential way for countries to try to do better around these challenges of global health. So here's just a few of the tools that are employed to try to assess how we're doing with the IHRs. I've highlighted one, the Joint External Evaluations, or JEEs, because I think this has become sort of the working tool for how we start to think about not only the science and the medicine of global health, but also the diplomacy of global health. So just a quick reminder of who member states and regions. Obviously, some of these regions are much more replete with spillover interfaces than others, but all have important jobs to do in terms of being able to bring their country along relative to their global health capacity. So this is just a quick run through of, what does it mean to have a joint external evaluation? So it is a voluntary thing. The countries say to the WHO, okay, we would like to do this external evaluation. And remember, these documents become very public at the end. So they know what they're signing on for when they do this. The host country, very importantly, does a self-evaluation, maybe the most important piece of the whole process. There's a team identified that obviously is going to read that self-evaluation. They're going to come and do a site visit. When they're on site, they draft their document and begin to then seek review. When that document is complete and reviewed, then it's posted, as I said. And importantly, there's another entity, the Global Health Security Agenda, which Nahid is going to talk a little bit more about, that expands upon the infectious disease component of these reports and really helps countries, again, evaluate themselves and make progress. And then finally, the last dot there is these reports are no good at all if they're not used to make the system better. So you'll recognize this sequence is very similar to any accreditation sequence that some of you may have been involved in, but an important global mechanism for doing what we need to do around One Health, around global health, and specifically to bring some diplomacy tools to that. So I've copied from the JEE for Uganda, and you can just Google JEE in a country, and you will get the report. And so this is just a summary page, but I wanted to point out you have national. So these are technical areas, and there's several of them. But when we talk about the importance of diplomacy, you see the very first one is national legislation, policy, and financing. And my personal favorite, which we don't do well at all, and everyone has to do better at, is coordination, communication, and advocacy. And that is really where global One Health diplomacy, or diplomacy period, lives. But that's followed by these very important science-based areas: antimicrobial resistance, of course, the heart of One Health, zoonotic diseases. So I think Fletcher is particularly well positioned to engage in and support countries as they work through these very important tools of the JEE. JEE is not the only way we look at this, and very, again, appropriate to One Health. There is an organization called the World Organization for Animal Health, OIE, which is the OIE comes from the French version of that name. And it has a very similar sequence of self-evaluation and reports. And so, but in this case, they are focused on the professional capacity for veterinary services. And so the presence of these efforts through the OIE, the presence of the efforts through WHO are really important in and of themselves. But, and this is what I'll leave you with, what we find over and over again, you go into a country and the human database sits over here, and the animal database sits over here, and the digital health connectedness of those things is really far less than what you would want. And so one of our mandates for global One Health diplomacy, if you will, is to help countries, help the world do a better job of coordinating and working across lines, so that in fact we're not responding to pandemics anymore, we're actually preventing them. because we've found those interfaces, we've understood the One Health aspects, and we've actually been able to design and assess appropriate interventions. And so with that, I'm right at about 13 minutes, and so I will cede my time to the lady from BU.
Thanks so much, Debbie.
Let me get out of my screen here just a second. Okay.
Thank you, Dean Kite, for the kind invitation and introduction, and thanks, Debbie, for laying out the difficult part of the problem. I'm going to start. Are you able to see the whole screen, or are you seeing just the presenter view? I'm hoping.
No, we're seeing it right.
Great. Okay. I'm going to start by saying I'm going to say something radical on slide 5. And then to start from there, as was mentioned, huge part of my work is both looking at the policy aspects, but actually the medical and the public health aspects. So I'm that rare Fletcher breed that bridges both clinical, public health, as well as some of the policy issues, because in this world of emerging infectious diseases threats, you cannot separate the two, as Debbie said, and that technical knowledge and that policy knowledge go hand in hand in trying to influence change. So I'm going to start by saying that I have no disclosures. All the images are mine. And anybody who's portrayed in these images, there was a permission that was obtained from them. So this is just to reiterate some of the work that we do. A huge part of my last decade of experience in EIDs, emerging infectious diseases, has been partly responding medically, clinically, but then taking lessons from that and applying it both here in the United States as well as abroad when it comes to strengthening both our preparedness and our response. So I'm going to start with this schemata that I've sort of adopted from a paper that I use in my class often, and this sets up for the slide 5 radical presentation for a second. I want to walk through the steps of what it takes, once that spillover happens that Debbie's talking about, and they're happening at an increasing level. Every year and a half, there's a new pathogen that you see on the international scene. And part of that is not just detection bias. It's not simply that we're finding them more. It is truly that they're emerging at greater levels because over the span of my lifetime, I was born in 1970 something. The population of the Earth has doubled, and the impact on the milieu is basically forcing an interface between where humans live and where animals live, and allowing an opportunity where pathogens are basically spilling over either into domestic animals that live alongside us or into humans, either directly from wild or domestic animals. And not only that, but what you're seeing is that 2/3 of the new infections that we're seeing are actually from animals. They're zoonoses, and many of them are RNA viruses similar to what you saw with COVID-19. And so if we think that the threat of of pandemics is over, or that might be the last epidemic threat that we face in our lifetimes, I think unfortunately we might be in for a rude awakening. So what does it take? I think first and foremost, you actually need a patient to realize they're sick. And when these spillovers happen, in many cases, you may get an infection, but you don't get any symptoms. Or you may get symptoms, but it looks like fever, nausea, vomiting, diarrhea. What else looks like fever, nausea, vomiting, diarrhea? Everything in my field looks like fever, nausea, vomiting, diarrhea. And so you need to have the ability of patients to recognize that a new infection or a new illness actually is something that might be a new pathogen compared to something that's endemic, that's just been, ailing those communities or any of our communities for this period of time. The other is you need to have the ability to access care. Now, here's the issue. You can't access care in most part of the world because there's a gap, there's a distance between the next community health worker. This is the whole, over the last 40 years since the alma mater, maybe even longer at this point, 50 years, the whole goal has been to provide primary care at the farthest reaches of the world. And we haven't really done an excellent job in sort of bridging that divide. And so many in the world still live miles away from the ability to get medical, traditional, to get, I would say, allopathic medical care. And hence you see a lot more care that's provided by traditional providers and others. You then need clinicians to actually recognize that a disease is an uncommon disease and not just malaria. And here's a striking statistic. What we found is a 2014 study that showed that 60% of malaria cases worldwide are treated symptomatically. Nobody tests for that, right? So you come in, you have fever, nausea, vomiting, and you're treated for malaria, you go home. If it ends up being not malaria, and if it's Ebola or Crimean Congo hemorrhagic fever or Marburg, you may have that extra period of time, unfortunately, that you go home. You're infectious and you're able to sort of unfortunately transmit it to your family and friends, and that delay in diagnostics actually leads to increasing number of cases in communities. You then need a public health system that's responsive enough. And so just to give you just to step back 1 second, the perfect example of this laboratory delay is the West African Ebola virus disease epidemic. The pathogen that was the initial index case for that epidemic was in December 2013. It wasn't until March 2014, when the disease was in 3 major capitals in the West African sort of area where it was spread, that it was actually identified as the Ebola virus disease epidemic that we now know. It took months, and in that period of time, it was able to spread, as widely as it was. You then need a public health system that's able to response up. There's an entire sort of the efforts that Debbie was talking about that I'll go into currently on helping strengthen integrated disease surveillance systems, both at the national level, but also at the international level. And then you need national governments to assign priorities and resource. And I will point out to our own delay in response in last spring as a sign that it's not just whether or not you're a well-resourced country or not. It truly comes to political commitment and recognition that a pathogen could be a threat. And then you need international partners to respond quickly, right? So here's what the issue is. At the terminal end of all international surveillance for infectious diseases outbreaks are actually communities that don't have access to care. So here's my radical statement. We live in a world where we miss more spillover events than we detect. I actually think Debbie may agree with that. There are potentially a lot more diseases, infections that spill into humans that we never detect, because it may go past as something that is just a common disease. It's never detected. There's no testing of the blood to see if you have signs of infection from that, or that in large, what we've seen in large part in this pandemic is that people die without a diagnosis. And that explains why around the world you're seeing excess mortality 2 or 3 times larger than what the reported deaths from COVID are. Because in most parts of the world, people are not given the basic humanitarian right of knowing what they're dying of. The unique challenges in particular for emerging pathogens is, even if you want to do the best possible for these responses, you're limited by the fact that the science around them is evolving. And this week you may have seen a lot of brouhaha around Dr. Fauci's emails that were released that showed clearly over time how his own knowledge evolved with science over an emerging pathogen. What we know with these types of pathogens is the first 100 patients teach you about the next one. You're truly using the knowledge from the first 100 patients to improve the care of the next 100 patients, but also that's the period of time with the shifting scientific knowledge base that you are making public policy. And this is one of the most difficult things, because you are having to create, potentially policies that may have other detrimental impacts, right? The lockdowns is a great example. There are inability at last March to not know how well spread COVID was, led to our need to sort of have to close down society altogether to get a better idea of what the transmission rates are, how widespread the disease was, and how many people were really sort of already sick that we hadn't diagnosed yet. The other parts are that we don't have facile diagnostics, and this was another issue that we faced here in COVID, but this comes up in every emerging infectious diseases outbreak at the very beginning. You need to get the diagnostic machines, the primers, everything to places to help identify what is the disease that you're trying to differentiate from the disease that might be circulating in the disease in the community. Here's an interesting point. In West Africa, what this led to was Ebola treatment units that admitted many people who had just fever, nausea, vomiting, diarrhea, right, which could be malaria, typhoid, cholera. And they would sit in Ebola treatment units 3 or 4 days before they got their diagnosis of whether or not they had Ebola, or Ebola virus disease rather. And so that delay, it it doesn't allow our own ability to sort of get a handle of how big the outbreak is, but it affects the individual patient's outcomes. You need to balance research and response activities, because if you truly need to learn from the pathogen, then you need to put in sort of a agnostic way of understanding what treatments work, what vaccines work, and you need to do that while you're expending resources on the response itself. And then there is the ethics of actually conducting research during an outbreak itself. So I'm going to say a couple of things. In this is a photo that I took. I was doing a training of Ebola virus disease survivors in January of 2014, and about 60% of the people in this photo were already facing something we call post-Ebola virus disease syndrome. That's an entity that we recognize occurs after people survive the acute horrific infection. And when this happened, the world, went back and said, how could we not know that Ebola virus disease did this? And turns out many of the prior outbreak survivors faced the same thing. And the reason we don't know is because we don't stick around past the acute phase of outbreak. And if we don't learn, selfishly, we don't learn even about the full longitudinal, sort of a full longitudinal expression of what a disease does. And this is why, again, the health systems, strengthening the health systems support is so important to just basic response to emerging infectious diseases. And this is the other thing that I'll say, which is that, one of the things that we've discovered is early on, doctors and nurses will do whatever they can to save their patients. Hydroxychloroquine is a perfect example. Something looks promising, but truly to show that a drug works, that it's not going to cause harm, that it's not going to have marginal costs of taking away from effective therapies, you need to be able to do research to quickly answer those questions in the middle of outbreaks, in the middle of epidemics, in the middle of pandemics like we saw. So to the point of what did we learn, before COVID, we've had H1N1, we had the original SARS, we had MERS, we had, the West African Ebola virus epidemic. We've had at least 3 DRC outbreaks in the interim. What did we learn? Here's some of there are many initiatives that came out, that here are the 3 main ones that I wanted to stress on. One is the Coalition for Epidemic Preparedness and Innovation. This is a group of national as well as international nonprofit investments, as well as private funders that try to identify the most likely new pathogens based on the right, you see the R&D blueprint that was created by WHO. The WHO put together a list of 10 pathogens that they thought they have the epidemic potential. And CEPI took those and started making investments and trying to create medical countermeasures and vaccines. And they've played a big part in the work currently during COVID-19 through COVAX to help, for example, identify vaccines for COVID-19 as well as manufacturing capacity. The middle one is one that I want to focus a little bit more about. That is the Global Health Security Agenda. In 2014, President Obama signed a bill that said that we're dedicated to this multilateral effort that is meant to improve, right? If no one country is similar in its dysfunction in terms of the gaps that it has in responding to emerging pathogens. We all have a different history of public health investments. We have a different history of political concentrations. And so the goal of this was to bring together multilateral partners. And one of those tools that was created is the joint external evaluations that Debbie mentioned, because the goal was to determine that baseline capacity that already sort of that's missing, that exists and that's missing, that future investments can then be made on, and to create a roadmap of what those investments may look like from the process that Debbie was talking about. And the goal, the 11 packages for global health security, along with JEE, is actually evaluated, are the ones that you see here that are meant to prevent, detect, and respond to emerging pathogens. So how well have we done? If you're really curious about this, I really encourage you to check out the Global Health Security Index that's put together by Hopkins and some of the other organizations. They take some of many of the JEE scores and they put a index, and you'd be surprised to know, still the number of countries that are not able to meet the basic IHR core capacities. And the other part that I think it's a bit missing, both in GHSA as well as as well as the index, actually is something that we're facing right now, which is the existential and the moral crisis of global vaccine inequity. It doesn't address how we work together during pandemics. And it doesn't address the fact that, look, even when we came together to create something like the COVAX utility, which was meant to provide global access to vaccines, COVAX couldn't compete with high income countries who are buying up vaccines directly from manufacturers. And so the idea that you will still have a great amount of geopolitics and nationalism that plays into responses is not something that can be captured by any of the efforts so far. And you can see from this statistic that there might be, or this graph from the Economist Intelligence Unit, that there might be countries in the world that we're still vaccinating in 2023. I hope it's not true, because the idea of how widespread the damage is going to be in many of these communities is immense. There's the Rand Europe report that says 1 trillion USD for global GDPs would be lost per year if equity inequity continues. And not only that, but you're going to see increased detrimental impacts on health. The idea that new variants may develop, it's going to set back development. It's going to set back a lot of the efforts on public health, education, female empowerment, food security. And the longer countries stay in crisis, the greater the chances that the economic inequality defined by Gini coefficient will increase over the period of time. So I'm just going to end here by saying that there's a few things that all of you will recognize in terms of our lessons for COVID-19 so far globally to respond to these emerging pathogens, which is that when the fire is in one place, we can respond to it with a global response. But if the fire is everywhere, if it's a true pandemic, our supply chains cannot match that strain currently. The fact that global collaboration is needed to build scientific evidence quickly, the fact that pandemic response is too vulnerable to political interference, another one that we did not sort of pay attention to in our technical approach. The fact that there needs to be equity in distribution if we really want to come out of these kinds of threats quickly, and the fact that we are at the advent of a disinformation age when it comes to humanitarian crisis. So I'll end there, and thank you again for having me. I'm going to try to stop my share.
Well, that was fantastic. Thank you to the two of you. Questions are starting to come in, and I encourage participants or the audience to put your Q&A in the Q&A. I'm going to start off the questions a little bit while the questions come into the chat. So you described, but from both of your perspectives, I mean, Debbie, you gave us an overview of, where does this get sort of decided, and all the different parts of sort of the ecosystem that are touched by building a One Health response, or preparedness or readiness for One Health responses. And then, of course, Naheed, you talked us through, where these initiatives are now, the sort of these international initiatives around pandemics. And I've got two questions to both of you, right? One is, you talked about the silos, Deborah, but we're siloed at an international level as well, right? So we've got, WHO, OIE, UNEP, if we're talking about the encroachment on nature, which lies at the heart of the rise of zoonotic diseases. And then, of course, those institutions are international institutions, and they are as strong or as weak as the member states that populate them allow them to be. And we've seen lots of criticism of WHO as the story of what happened in the first 6 months of 2020 unfolds. But do you see any sort of, what would it take for us to be less siloed at the international level? And then a question for Naheed is about the money. So COVAX and CEPI, as I understand it, and maybe you could talk a little bit, I mean, they're sort of hybrid funded. There's big chunks of philanthropy in there, alongside from Bill and Melinda Gates Foundation and others, alongside governments. So it seems that these seem to be critical elements of the international cooperation needed for pandemic response, and then to build One Health. And we're relying on, some philanthropists to build that infrastructure. Do you think that, I mean, that might not be a bad thing, but I mean, it would be interesting to think that if we're hanging by a thread, as it were, as a civilization, that we rely on a few individuals really to build our response. Maybe the two of you could talk about that, and then we'll open up to the questions that are coming in. Debbie first, perhaps.
Sure. I guess I want to go back a little bit to the basics and say, what are the economic benefits of investing in global health before you have a pandemic? And so the World Bank analysis of investing in 129 World Bank client countries in prevention and control of zoonotic disease and bringing those countries up to the OIE and WHO standards was estimated to be about 1.8 up to about 3.5 billion per year. So compare that to the expected value of preventing a pandemic, which is about 30 billion a year. And so for an example, MERS, only 186 cases cost the economy in terms of losses 700 million. And so I think to both of your questions, part of that answer is a very cold, hard, it's economics. We should break down the silos and we should do better at working across lines because it's going to save us money. And so at the end of the day, that also speaks to your second question about, how do you sustain this? And so sustainability and how we actually don't have to do this every 10 years because we figure out the root causes, I think is very important. And I think one element of that, which we tend not to focus on as much as we should, and that is the element of this, which is behavior change. And so we can do a lot of preparedness and response, but if we don't walk back to why did the spillover occur and how do we prevent habits in the household or by date palm sap harvesters to do that in a safe way, then we're just going to keep going around this track and someone will have to pay for it. But if we do it in a sustainable way, not only do we perhaps avoid some pandemics, but we avoid a lot of economic loss.
Yeah, I think it always comes down to money because we live in a cycle of panic and neglect, not my words. It comes from a report called The Neglected Dimensions of Global Health Security that was written after the West African Ebola virus disease epidemic. So here's the issue. The body that we designated as our common platform through which we are going to do this type of work, WHO, steadily has been losing support from member states. Quarter of its budget comes from the Gates Foundation. 86% of the collection rates, so basically you've had difficulties having member states sort of pay their dues, and the real-time assessment in dollars hasn't changed. So there's been no adjustment in inflation, and 93% of the funds were donor earmarked of the voluntary funds that were given. And by the way, voluntary funds now make up 80% of WHO. So what they're doing is what the donors are telling them to do, because that's who's paying the money. And if we really want to invest in a global sort of move forward, we need to strengthen the WHO. And that was to the question that was in the chat from Sylvia in the group. That is one of the things that's coming out both from the panel, the independent panel for pandemic response, as well as the World Health Assembly discussions in the last week, which was we need to strengthen the WHO. We need to give it more authority to be able to do this. The other ideas for financing include a global tax. There's Ilona Kickbush is a good person to look at if you're interested in this work. She and some co-authors suggested this idea of a global tax that creates global greater common goods to help build this stuff. We do know that this is something that we need to do in a way that is sustainable and separated from political cycles, because after every epidemic that I've been part of, a huge rush of money comes in, and then the next political cycle comes around and the funding gets removed, programs get shut down, the intellectual and human capital that's built is no longer taken advantage of because we lose those jobs and we lose that intellectual capital.
So Rachel, could I add one quick thought to what he just said? So we just finished a symposium at Fletcher School, and Naheed was part of, she's a dual personality, right? She's a Fletcher person, but she's a BU person. So she was involved in the planning of it, as was I, and Ian Johnstone and Diana Chigas and others, Liz McClintock from Fletcher. But it was controlling infectious disease outbreaks, conflict, security, and global health diplomacy. And one individual at one point during the discussion, and we had folks from all over the world, particularly from DRC, focusing on the Ebola outbreak and lessons learned. And he pointed out that the budget that came in for dealing with, the outbreak was more than the national budget for health for the country. And so your point about, it is feast or famine, we need to figure out a way to deploy these funds to strengthen health systems, strengthen global health before we get the pandemic.
So this is a phenomenon beyond pandemics, right? We have threats in plain sight. We don't invest, and then we have a crisis, and then we throw money at a problem, and then we panic as well. And this global taxation concept, it'll be interesting to see if the G7 agrees on a corporate tax being negotiated while we talk for agreement next weekend, as the beginning of perhaps a new sort of way of thinking about raising revenue. The Tobin tax has failed on multiple occasions, but maybe the strength of this pandemic forces us back to look at these models. Naheed, you answered in part Sylvia's question, but maybe because of the other participants, the IPPR report. So this is the report that was led by former Prime Minister of New Zealand Helen Clark and former President of Liberia Ellen Johnson. Can you talk a little bit about what that process was and what it said, and what will it lead to?
I hope something. Having lived through this after the West African Ebola virus disease epidemic, I hope that so this is a process this is the third report that's come out from an independent panel that's describing both the global response as well as WHO's response. And they identified, both, again, aside from the WHO strengthening the importance of just global investment. They also identified the global investment in both these types of preparedness issues, but also the basic strengthening of things like, a perfect example is vaccine manufacturing, right? The continent of Africa imports 99% of the vaccines that they administer, and that's been going on for decades. And we live now in an age of epidemics, as I mentioned, and how have we let that happen, right? The idea that we tend to sort of focus more on the response than the epidemic. The report does identify other sort of like other criteria in terms of also potentially pushing rich countries to make more of a significant impact and contribution in terms of sort of moving forward. I don't know what's going to come out of it. As you know, there's a pandemic treaty that was proposed by some of the countries, 20 countries, as WHO. It was discussed at the World Health Assembly, and it would have teeth. It would actually have commitment. I don't know if the United States is going to sign it. I know they signaled towards the end of World Health Assembly that they're interested in discussing it, and it was pushed to the fall for further discussion. What was signed instead was the Rome Declaration, another Rome Declaration. Debbie will know the ones that are already existing in One Health around that, but that sort of again reiterates the importance of these types of commitments. I hope something comes out of it. I don't know what will, Dean Kite.
And Debbie, just on this point, it seems that a lot of the recommendations that are coming out of these reports in terms of what we're learning in the early days of examining COVID, that obviously the focus is often onto the public health system and the human health. Is that because that's where the newspapers are focused, or do you think the strength of the recommendations that are needed for this sort of upstream conversation about how we encroach on nature, or what this means for animal husbandry, what this means for the investment in the animal health side of things, is that overlooked in these immediate responses, or it's there, but the newspapers, the headlines are, the recommendations that would pertain to how WHO organizes itself or something like that?
It's an important question. USAID for the past really 15 years, ever since the zoonotic avian influenza outbreak, has invested in One Health and has invested in trying to install One Health platforms in many of the countries, low and middle income countries, in which spillover often occurs and outbreaks are documented. And so by doing that, they really focus on what you just talked about, the idea that we have to invest not only in the Ministry of Health, we also have to think about the Ministry of Agriculture, of Forestry, of the environment. And if we're first and foremost bringing those ministries together to talk to each other and to understand the concerns that each share, and the shared challenge of financing, which again, the lack of financing of One Health platforms is probably the single biggest reason that they haven't taken off in some countries. But I guess the bottom line is the framework has been, in many cases, installed, but it's not functioning very well. So to your point, that hasn't been particularly sexy in terms of media coverage. What has been a lot sexier, though, is the wildlife interface. And so clearly with COVID, the wildlife markets, wildlife farming, the rather dramatic announcement by China fairly early on that they now were restricting consumption of wild animals for humans. And so that was intended to break that spillover chain. Unfortunately, there's no restriction on using of these wild animals and purchasing them in wildlife markets for medicines or for other things other than consumption. So there's big holes in that particular policy, but it got the attention of a lot of countries, especially adjacent countries, that then had to ask themselves, all right, do we ban this industry? Do we do that? There's economic results from that. I think that's playing out now. And because humans, I think, are inherently, maybe sympathetic is the wrong word, but they're concerned about the environment, they're concerned about wildlife, and they do want to hear about that in the media. So our challenge is to make rational policies, I think, not ones that are sort of knee-jerk reactions to that pressure, because it really is all, again, about walking it back to where are the interfaces, what are the pathogens, what's the biology of pathogens, how do they move? Now, how can we intervene? And again, behavior's got to be part of that discussion.
So it just, there's a question in the, that's come from Leslie Puth. Leslie, hello. Leslie is a absolute rock upon which a lot of the activity of our board of advisors is built, a very important part of the Fletcher community. So welcome, Leslie. And her question is, I think, primarily to Naheed. So can you describe the role of gain of function research, which has been highlighted recently because of the conversations around the role of the virology lab at Wuhan? You know, I think it would be good to hear your perspective on what that is, how important that is in the effort to control or manage future disease outbreaks.
Thank you, Dinka. So I'll start by just two things. One, by just saying that I am not speaking in my capacity as the Associate Director of an NIH-funded biosafety level 4 laboratory in the United States. Gain of function, to describe what gain of function research is, it is something that's taking a pathogen and giving it new features that potentially make vaccines ineffective or change the way the disease is transmitted, potentially to make it more virulent or be able to affect humans more, to evade diagnostic tests. And the way that generally the reason that it's done is to help us understand how viruses will change to potentially to evolve, and could we take that knowledge and build vaccines and diagnostics based on that. And that's really sort of the medical, academic, public health reason for having that. The concern is that, the same knowledge, and this came to head with the H5N1 studies, the avian influenza studies that led to potential creation of viruses that may be more transmissible around humans. And there's a discussion of, could this be dual use research that could be used then to harm humans from nefarious actors, malicious actors, and things. Since that happened, there's been a lot of oversight here in the US over dual use research, and globally as well, in terms of what is reported, how it's funded, how it's regulated. And so there was a ban and then a moratorium on it for a bit, and then it's now sort of restarted with that oversight. Here's the trouble. To diagnose people in the world, we need to create laboratory capacity. It can't all exist in high-income countries. The question is that, to really understand pathogens, both to diagnosis and then understand pathogens, and have a research agenda be driven by the countries that are being affected by many of these diseases where they're endemic, you need to build, a biosafety level 3, biosafety level 2 capacity. That's where majority of the risk already exists. Biosafety level 4 laboratories, which have come into focus because of Wuhan, interestingly enough, they're so expensive in most places. don't have the biosafety, biosecurity oversight. So it's unlikely you're going to see a proliferation of the biosafety level 4 labs the way the sort of media is sort of making it out to be, because they're very hard to sustain. But unfortunately, that doesn't take the risk away. You know, with new technologies like CRISPR, with just basic knowledge, as I think I'm trying to find that quote from Hillary Clinton that I think is so telling, that I use in one of my courses, which is basically that you only need here's what she said: a crude but effective terrorist weapon can be made by using a small sample of any number of widely available pathogens, inexpensive equipment, and college level chemistry and biology. So that threat already exists. It doesn't just exist in maximum containment laboratories, right? And so I think, yes, we should definitely have oversight. Yes, we should definitely limit the number of kind of gain of function tests, but we need to separate the threat of bioterrorism and biosafety and biosecurity from just gain of function research, because and from biosafety level 4 laboratories, because that exists already outside of those maximum containment laboratories, because those are more regulated, like I said.
So there's a couple of questions about the sort of the moral dilemmas that we all face, right, in sharing of vaccines or in pandemic response. So I want to ask you both about this issue of sort of solidarity, really. So you can make the economic case, you can also make the public health case, right, that if we don't take care of others, we remain vulnerable. So there's no sort of building a wall around ourselves and keeping the pandemic out. So that can be intellectually understood. Then there's politics, right? So are you going to vaccinate all your 10-year-olds before you share vaccines with other countries? And the WHO has come out quite strongly, I think, during the WHA and afterwards, calling on developed countries to share vaccines now, rather than continue to vaccinate their own young populations. And then there's sort of the general question of how do you sell, if the economics are clear and if the sort of public health arguments are clear, how do you sell solidarity as a sort of way of working? I mean, how does vaccine diplomacy become a positive thing as opposed to sort of the rather negative connotation that's been associated with different countries, you know, either doing or not doing, not working with countries or not working with countries from a vaccine point of view? I mean, have you taken heart over the last 12 months, or are you sort of a little downhearted at how things are turning out? And what do we do about it?
I think that's a difficult question, and it's constantly evolving. And so I guess, you know, I'm not sure I have any insights that would be particularly useful on that, except to say that it is about that spectrum from international to national to regional to local, and anything we can do to, along that spectrum, convince people that there is economic value, there's personal gain, their families benefit from working together, then that is kind of, I think, changing the hearts and minds kind of approach and communication, actually risk analysis and risk communication at a level where people can understand it, to me is a basic tool that we still could do a lot more work on.
Mm-hmm, mm-hmm.
I'm horrified. I'm horrified because I'll share something personal. I lost 2 of my aunts and a cousin in India during the 2 aunts of the last recent surge. Neither one of them could access a vaccine. And many of my family members still can't. Extended family members in India still cannot access the vaccines. And I completely understand that countries need to ensure their own populations are vaccinated. But I think the whole question of should you vaccinate your kids versus the global community, I think that's a zero sum that doesn't exist. Kaiser Family Foundation says by fall, the US will have about 500 million doses in access. And by the end of the year, we'll have about 1 billion doses in surplus. And the production of most of those doses will finish this summer. So we may not have them all at hand, but we're about to get a lot of doses. And most of the states, you know, most of the communities here in the US have gotten to a point where they've been able to have the capacity to vaccinate everybody who wants to be vaccinated. We're not quite there yet. And so the onus is on us because we have the most number of doses. We competed and won to get most number of doses from manufacturing companies. Because, a big point that Jake Sullivan made yesterday in the announcement of the distribution of the 80 million was, look, we're not going to use this as a geopolitical advantage the way that Russia and China have done in terms of the vaccines. And I think that's a good thing. And they signaled that by giving 75% of that to COVAX and saying COVAX should be able to distribute it through the international mechanisms that exist. We're not going to influence that. And then 25% that they're not giving to COVAX, they're using not as a geopolitical strategy, but by putting it to places that are where there's surges happening. Latin America, in May saw like 30% of the COVID deaths, and despite being only 8% of the global population currently. The tough part is 80 million doses is only 2% of what's needed to vaccinate low and middle income countries. We are nowhere near what's needed. And it will have to be a staged sort of response. One is high income countries donating their surplus. And by the way, the surplus that I mentioned, the 1 billion, is after you vaccinate everybody over the age of 5 and you have stockpiles. And in some scenarios, you gave enough to Mexico and Canada, it would still be just under 1 billion that you would have left over. And so the first will be the surplus. Then it has to be dedicating raw materials to create more vaccines in factories that exist outside of the US. So India, some of the other places that have strong vaccine manufacturing capacity. And the third is some of the work that's currently being done, aside from the IP waiver support, is actually having some sort of cooperation to transfer the tech know-how, and in the long term, helping build vaccine manufacturing capacity in resource limited settings.
I was just about to jump in and say that, because I think that last piece is you're back to now. You're not responding, you're preventing, right? You're building sustainability, you're building capacity before you hit the pandemic. And the IP is important, the actual manufacturing, the supply chain, all of that, we don't deal with it unless it's a crisis. And so that's unfortunately the mindset.
Yeah, I was just going to say one thing. People are saying the IP and the manufacturer is going to take 1.5 years, to do anything about. So what does it matter? Well, you saw the map. We're still going to be vaccinating most of the world for years to come for this disease before we even move on to the next threat.
So we've got a question in the future, which is sort of like, if is really about this prevention. Then, so if you could design a One Health network to operationalize the One Health approach and elevate our mindset and elevate that mindset into government and policymaking, what would it look like? So would it be a network between universities and governments?
I wish I knew.
Do you have one in your back pocket, Deborah? I mean,
well, I wish I knew who asked this, because it's a softball at Tufts, because we've for 10 years been involved in the Africa One Health University Network and the Southeast Asia One Health University Network, which again, USAID invested over the past 10 years to create these networks. The focus of these, which you probably didn't read about as much in the papers as you read about PREDICT. PREDICT was also part of the USAID investment, but it was about virus hunting and finding unknown viruses. The One Health workforce and the Respond piece of those programs, it really gets at this question. It established a network that its primary focus was education, was building capacity, doing gap analyses of curricula, and training the next generation of One Health professionals. The value in that being those people then go off and populate the ministries. And if they happen to be in the Ministry of Health, they understand the value of speaking with the Ministry of Agriculture. So first and foremost, I would say laying the groundwork for capacity development in workforce is key. And so to your question about, is it about universities, is it about governments? I think they're all connected, that the universities are a wonderful, stable place to start with a One Health network, and we have started. There's a lot of positive news there. Translating that into how governments then do their business and do policy, I think is a little harder. But again, it is happening now with the One Health platforms. Those were also funded through investment by USAID, but they are in some sense languishing, right? They are now underfunded or have been underfunded. And so that to do the work that we know needs to be done, we really have to continue to invest. And so I think connecting the universities, the policymakers, funding those platforms, those are some of the ground level things that we're missing and the gaps that we have to fill. So great question.
So, and the heat on the health side of things, I mean, we always underfund prevention. and this is becoming a bigger and bigger issue, right? I mean, just, for example, the food system, the food that we eat today, kills as many people as it keeps alive almost, right? We're eating the wrong food. People on low incomes can't get access to healthy food. I mean, so these kinds of system, do you think this pandemic has forced policymakers to the point where we can actually sort of think about system design a little differently?
I think that it might lead to innovation at the international level of how we improve collaboration. It may improve sort of the investment in the science, which are the easier, those sound hard, but those are actually the low-hanging fruit. What we really need, right, is that last mile or first mile, however you want to describe it, that actual health equity. And that is tied to sovereign nations' commitment and investment in their own healthcare systems. And part of that goes to governance. Part of that goes to, the ability to have and sustain that in a way that meets the country's sort of a national agenda rather than donor agenda, which has been an issue, right? Because I think that some of the things that we've seen is and I think it's changing. I honestly think of the last 10 years as changing, where you're seeing a lot of vertical programs in disease. We've been talking about vertical programs in disease since diarrheal diseases and HIV. Over the last decade or so, the integrated disease surveillance platforms that they've been trying to develop that says, if you have HIV and you have tuberculosis and you have malaria sort of, infrastructure built in, how do you combine that under the country's own public health system that looks for a horizontal net? That's where a majority of the work is, and how sovereign nations in the rich part of the world can help sovereign nations that have more limited resources help realize their own sustainable health systems rather than the diseases that specifically threaten what they perceive as threatening the global environment, right? It can't just be that we're worried about the diseases that are going to spread beyond the borders, because that's what global health security has been. It's about like the diseases that threaten all of us. It needs to be, I think, beyond that, moving beyond that, because we don't know what diseases will threaten us, because we don't know when it's going to arise. We need to have it be a more general approach in health systems strengthening.
Maybe one other thought on that is you've probably heard the phrase decolonizing development, and the idea that, the way we go at working with countries to develop capacity really needs to shift so that it is more sustainable. I just heard so many stories about investments in laboratory and equipment, but then when the grant ended or the program ended, it basically fell into disrepair. It was not usable anymore. So we haven't gotten the formula right on that, and I think we really need to keep working on that. I think Samantha Power, the new administrator of USAID, is going to be a very interesting addition to the mix. She's obviously former UN ambassador, and so from the US, and so she clearly understands sort of the multidimensional nature of building or developing capacity. And so I actually do hope we do more than just talk about that, and that we actually see change in the way we go at some of our efforts.
So there was another aspect of this, sort of maybe the beginning of a reset in, I don't know, I suppose values at the highest level. There was a question about animals or pets actually that popped in. And the question I wanted to ask is, does this force us to have a slightly different relationship with animals? I mean, because at the end of the day, it is our relationship with nature and our relationship with the rest of the animal kingdom, as it were, that's at the root cause of how these zoonotic diseases have become such a feature of our modern life. I mean, beyond the question of whether you can get COVID from your cat, I mean, does this force into policy making a different set of questions?
I certainly think so, and I think it does kind of sadly, I guess, go back to the economics again. That if you can prevent the spillover, you've saved yourself billions of dollars. And so, how do you do that? You change behavior. If there are mining communities in the remote areas of a country that subsist on bushmeat, and that's where they're getting their next meal, and you can fix that, if you can provide an alternative source of protein of a diet, then now you've decreased the odds of a spillover at that interface. If you can pay the farmer enough money for his crop or her crop to prevent them from having to burn down more forest and deforest and destroy habitat, you've actually decreased the risk of spillover from those habitats. The wildlife markets and habits of what people consume culturally, as well as, again, it's not just about food, it's about the medicines. All of that is going back to how do we change behaviors of people who are just trying to feed themselves and their families, and respecting environments, respecting the animals in them, to your point, I do think is becoming a growing focus. But in many parts of the world, that's not going to motivate people to change their behavior. What's going to motivate the change of behavior is the things that really hit home for them, feeding their families and keeping their families healthy.
So the question, we're coming to the last sort of 15 minutes, and if there are other questions, please post them. What I wanted to do was, but you've both talked about the future. You've both talked about everything that the things that we're learning, the things that have been tried before, maybe not funded consistently, or they've waned as attention has moved on to other crises. But if we really were now going to build back better, as they say, if we were going to invest in the infrastructure that would allow us to be able to respond to what I assume we expect to be sort of waves of these kinds of pandemics over the next 10, 20 years, beyond the things that you've already mentioned, I mean, well, let's say I was going to give you a one-way ticket on a private plane to Cornwall next week, to the G7, or to Italy later, to the G20, or to the General Assembly. Is there a sort of drop-down list of things that we should agree and persevere with at the international political level that aren't there, or aren't in clear enough relief? If you were given 5 minutes in front of those leaders, what would be the 3 things you would ask them to do? Naheed, you've got it. I know you've got it on the tip of your tongue. I'll come to you first.
Yeah, I think first and foremost, I think that we have to strengthen our surveillance, and we do that not through just, as you said, human, but also animal surveillance. And there are a lot of projects that are underway. The Global Virome Project that aims to sort of evaluate all the viruses with the capacity to spill over into humans. There are not as many overarching efforts aside from the Global Health Security and JEE to help build capacity to create that kind of surveillance for diagnostics. I've worked in parts of the world where entire wards exist where people do not know what they're dying of. There are wards in this world, and there's a reason why. There's a reason why Gates Foundation has something called CHAMPS. It's a childhood mortality project where they try to do autopsy and pathology studies of under 5 deaths, in the continent of Africa, because it's so little is known about even what causes in many areas deaths in under 5. We need to know what we're dying of. We don't even have a handle on that, and surveillance is an important part of that. The second is linking that to healthcare capacity building, or healthcare capacity strengthening, I should say, in many of these areas. And then third is investing in the science that's going to include efforts like CEPI to look at more likely pathogens that might sort of come on the scene and become threats, and then equity, health. So 2 other things: equity. We have to work on equity within our communities, and we have to work on equities across our countries. We have to make a better effort so that we're recognizing in the setting of COVID how this mismatch in global vaccine coverage is going to lead a threat to everybody. We have to recognize this will happen every time there's an infectious disease. And the last is disinformation. I think that as a technocrat, I was surprised by how much politics, geopolitics, and disinformation debilitated us this year. We're at the advent of that age now. You're only going to see that get worse with the next outbreak, and we need to come up with better ways to combat disinformation during a very confusing period that is an outbreak response period.
So I certainly would concur on Naheed's list. I would go back to the tools that we have to do that. And so we have the international health regulations, we have the JEEs, we have GHSA to assist countries in meeting those capacities.
I think,
she's frozen.
yeah.
All right. So while she comes back, my next question is really, given all of that, what should university? Oh, there we go, Debbie. Back to you.
Sorry, I don't know what happened here. Here I sit in the middle of Massachusetts. I should have great internet coverage, but no, I said briefly that I certainly endorsed everything that Naheed said, but I'm frustrated that we have in place some important tools through the IHRs, the JEEs, the GHSA to really help countries develop their capacity and to help them improve their scores on these indicators. So if you look at the indicators, it's pretty much all there. We need to do a better job with those. Secondly, I think elevating the incentives for collaboration and working across global health, whether that's NGOs to governments to educational institutions, we need to do a better job of really coordinating what we do pre-pandemic, during, and post, all the way down. And importantly, and I think Naheed opened with this, that we often don't even debrief at the local level after an outbreak. And so we can't forget any piece of that spectrum when we talk about collaboration. And what really underlies that collaboration is the third thing, and it's very related to what Naheed said about disinformation, but it's maybe the step even before that, and that is to make a greater effort to educate people to the importance of these dimensions, these interfaces between animals, humans, and the environment, and to really, it's like when you tell a child, no, you can't do that, but you don't explain to them why they can't do it. They're probably just going to wait until you're not there and go do it again. And so what we need to do is help people understand risk, help them understand how to intervene in it, and to then that will lead us to sustainability of habits that will make it less likely to have more spillover.
The question I want to then segue into is, so this seems to be the mother of all interdisciplinary issues, right? It can only be solved in an extraordinarily interdisciplinary way at the local level, at the national level, and at the international level. Of course, I spend a lot of my time trying to work out how to make that happen at the international level better. And it seems to me that over the last 20, 30 years, the tendency is that whenever you need to work in a slightly innovative way or in a slightly different time frame, or if you need to sort of push the issue out a little bit more into the world a bit quicker, or if you need to build interdisciplinarity into the international system, you end up setting up something outside of the traditional organization whose responsibility it is. Often that gets funded then by philanthropy and maybe private sector participation alongside government, and then that sort of advances an issue, and then you hope that it comes back into the governance of the system, as it were, and then you try to move everybody forward, which is fine when you have 100 years to evolve an issue, right? And so we're working on this sort of like sense of urgency now. But what does that mean for universities? What does that mean for Tufts or BU for that matter? I mean, how do we, in the way in which we work on these issues, strengthen the underlying fabric of interdisciplinarity so that perhaps national government, local government, international governance is able to cope better with these things?
That's a wonderful opportunity for us to, I think, talk about what is right now an effort at Tufts, the Global Health Diplomacy Initiative, which is to try to take the talents at Tufts across these various schools that we mentioned earlier that have distinctly different talents, but they're very synergistic when it comes to understanding and advancing global health. And the good news is when you train folks like Naheed and they go off and they do well and they get their own centers, then you expand what can happen at Tufts to even a Boston consortium of how do we train or educate the next generation of health attachés, of people who will inherently want to behave in these collaborative ways across lines. And I would say, I'm sure Naheed has some observations on that.
Yeah, I was going to say, I think that one of the things that I realized teaching my course over the last 5 years or something at Fletcher is that the most important thing is to take people from different disciplines and teach them the same vernacular. honestly, that is the biggest barrier. You'll be amazed that people work on the same problems, give it a different name, and stay within their silos. And bringing students, from the medical side, the public health side, the policy side, the environment side has been a lesson for me in terms of how we evolve together in answering questions that are multidisciplinary. We don't need to get our answers and all come together in a room. We need to get together in a room and develop answers that are more multidisciplinary. And I think that starts at the education level, as Debbie said. I did want to say a little bit about our center. If you have a chance to check it out, is the Center for Emerging Infectious Diseases Policy and Research. And to that answer of how do we do this, I think that what we've done is we've tried to the whole goal of the center is transdisciplinary research. It's national and global capacity strengthening, and it's training. And the four things we're focusing on are resilience at the community level, improving our ability to protect populations that are going to be hard hit. We know who that's going to be. My experience in outbreaks always tells me it's going to be, communities fracture along lines of known weaknesses. The outbreaks prey on people we leave out in the cold, and health system strengthening, allowing health systems to have surge capacity, giving them the strength to be able to respond more quickly and nimbly with additional funding and preparedness and training. We're also looking at governance issues that we talked about all through today, as well as trust, disinformation, misinformation, the idea of state-sponsored disinformation during outbreaks and how that's played a role. What's the best way to communicate scientific uncertainty from public health experts to the rest of media? And the last bit is innovation, both social and technical innovation, and how we use those. What's on the horizon? What are the challenges with those new technologies, et cetera?
Well, we're truly blessed to have scholars of your standing and dexterity in our midst. And I hope, for my part, that Fletcher, as one small part of this this ecosystem that is needed, will continue to grow our engagement in health diplomacy, and in One Health diplomacy in particular. I think there are real questions about how we cooperate at the international level, what it takes to be a national leader that can be committed to international cooperation and deliver on the domestic agenda. I often say that the mechanisms of international cooperation have suffered from the benign neglect of their supporters, as well as the hostility of their opponents. And we find ourselves at a moment where it's difficult to imagine how we work our way through the problems and the existential threats that we face as a society without deeper and more radical collaboration. And I think that you've both laid out very clearly for us why that's so important in the response to this pandemic, and unfortunately to the pandemics that we could expect to see in the future. I'd like to thank both of you for joining us today. I'd like to thank our wonderful alumni for being part of this conversation. I'm going to hand back now to Corey, who will bring this to a close, but to say that it's been my privilege to be in conversation with you today. And I look forward to seeing you both in future. And Naheed, good luck with the new centre. And Debbie, thank you for your leadership, and good luck with the big initiative of Tufts. Corey.
Great, thank you, Dean Kite, and thank you to the panelists. This was great, and I think yesterday and today were just great examples of how Fletcher and Tufts are really working to combat the really serious problems facing the world, and we're really lucky to have such great experts here. And thank you to all the alumni for joining us today, and other guests, and for your questions. We will be posting the video from both today's session and yesterday's soon, so feel free to share that with anybody in your networks. And please look out for more events like this in the future from us. So thank you again for joining us, and have a great day.